Dear friends, it is of great honor and pleasure for me to congratulate you with the opening of the Bulgarian National Congress of Spinal Surgeons. I have visited Bulgaria more than 10 times, and I have a lot of friends here. I mean, Professor Vladimir Stavrev, Professor Stefan Stanchev, Professor Luben Stokov. Unfortunately, this year I was unable to visit Bulgaria because of well-known circumstances. But I hope that the next year everything would be okay, and I will see you once again. I wish you success and interesting session. Thank you. Dear Chairman, dear colleagues, autofusion in children with early onset scoliosis was first seen in 1979 when Moore implanted a Harrington rod subcutaneously in young children, exposing only the hook sides. In this paper, Moore briefly mentioned spontaneous bone block in a series of 20 children. Autofusion was detected in 4 cases, but never at the top of the deformity, but only at its ends. The definition. Menapace and our co-authors studied in detail a group of 28 patients operated with traditional growing rods and magnetically controlled growing rods. They determined that if 2 adjacent vertebrae move together and as a whole and/or are connected by a bone bridge, such a segment is located in the state of autofusion. Menapace and co-authors proposed an estimate of the length of the autofusion obtained by dividing the number of block segments by the total number of segments on the altered part of the spinal column. Grades 1, 2 are regarded as low, grades 1, 3, 4, and 5 are regarded as high. In 2014, Zhivkevich and co-authors considered the development of autofusion as mostly harmless biological reaction to the patient's routine motor activity in the presence of polyaxial fixed implant. The authors proposed a classification of autofusion depending on the location of newly formed bone masses. Type 1 at the implant fixation points, type 2 along the length of destruction rod, and type 3 reossification in the area of separated rib blocks. Surprisingly, the first mention of the development of spontaneous bone block refers to the cervical spine. O'Brien described this condition in 1975 as a complication of halopelvic traction for severe spinal deformities of various etiology, and in all cases bone blocks formed in the cervical spine. Both the anterior and posterior parts of the vertebra could be involved in the zone of spontaneous block. The pathophysiology of autofusion has not been sufficiently studied. Chalmers and co-authors were apparently the first to investigate the possibilities of bone development in soft tissues, pancreas, liver, kidneys. They also concluded that 3 conditions are necessary for bone induction in soft tissues: the presence of the inducing agent, osteogenic progenitor cells, environment that allows the processes of osteogenesis to take place. Modern authors tend to believe that the formation of autofusion may be the result of the influence of number of factors: immobilization, local damage to the paraspinal muscles, periosteum and soft tissues, direct contact between the metal and spine, and finally the ability of immature bones to quickly heal fractures. The mechanism of regulation of this process is still not fully understood. Discussing this study, Gronefeld and Hell emphasized that when using Webster, damage to the periosteums is the result of surgical manipulation, flexibility of the implant, its migration and increasing metal pressure on the bone at the point of contact. The same authors note a significant correlation between the development of outer fusion and the amount of correction of scoliotic deformity. The authors also studied the issue of risk factor for the development of outer fusion. They were able to identify not only risk factors, but also so-called protective factors, in the presence of which the possibility of development outer fusion can be regarded as reduced. Risk factors include the age of the first implantation of growing rods, less than 8 years, unplanned operation during the period of stage destructions, and the cup angle of the main curve after the first destruction of more than 30 degrees. Protective factors are the preoperative spine height of more than 30 centimeters and the primary implantation of MCGR. The frequency of the outer fusion formation is interested in this. Many surgeons are interested in this question, but the amount of reliable data is very limited. The information we have collected indicates that the frequency of outer fusion formation is very variable. Among 167 patients with early scoliosis of various etiologies who underwent final fusion surgery after stage destructions, spontaneous bone block was detected in 84, 50%. The consequences of development outer fusion in growing children. The fact that the formation of outer fusion restrict the growth of the spinal column and prevent the correction of scoliotic deformity using stage destructions has been known since the use of growth-friendly surgery in children with early onset scoliosis. Outer fusion is regarded as the reason for the so-called law of diminishing returns. This phenomenon was described by Dr. Sankar and co-authors in 2011, and its essence boils down to the following statement. In the stage treatment of early scoliosis, each subsequent destruction is less effective than the previous one. According to the Sankar, the first destruction provides almost 50% correction, and subsequent ones generally increase the corrective effect very slightly. Outer fusion and magnetic rods. Initially, it was assumed that the use of MCGR technology does not predispose to the formation of bone blocks in the destructor bed. In 2017, Gardner and co-authors have shown that quite convincingly, that the Sankar rule does not work when using magnetic rods, at least in the same way as in the case of traditional rods. Gilday and co-authors found a correlation between the destruction value and the distance from the skin to the magnetic actuator, 2% elongation per 1 millimeter of tissue depth. Another possible reason for failures when using MCGR is slippage. Cheng and co-author define this as an ability of the inner magnet to make a complete revolution when stopped and returned to its static position. The risk factors is the distance from the outer magnet to the actuator and the increase in the distance between the inner magnets. How to limit the development of the fusion? There are two systems of growing rods designed in such a way as to reduce the likelihood of the developing of outer fusion. One of them is a semi-constrained growing rods. This difference is the possibility of axial rotation displacements of one component relative to another. The authors are Butors and co-authors examined the results of treatment of 28 patients and stated that final fusion gave an additional correction of 20 degrees and the increase in TH1-S1 distance was 32 millimeters. That is, the data obtained indirectly indicate a minimum level of outer fusion formation. The second system is so-called minimally invasive bipolar technique proposed by Milady. The technique is based on the gradual correction of deformity using the viscoelastic properties of the trunk tissues. The telescopic structure covers the deformation and maintains tension between the ends. The proximal grip consists of two laminar pedicular pairs on both sides for 4 or 5 segments. The distal one is formed from pedicular screws, 2 or 3 on each side. The grips are firmly connected with 1 or 2 rods and with minimal damage of soft tissues in order to reduce the risk of scarring and outer fusion. Outer fusion and final fusion. A number of authors with significant clinical material have expressed their views on the operation of the final fusion. There are 3 variants of the technique on the final operation performed at the end of the staged destruction period. Replacement of the destruction rod with segmental instrumentation and posterior fusion, preservation of the destruction rod and posterior fusion, and removal of the destruction rod with or without posterior fusion. Literature data show that surgeons do not have a consensus on these 3 operations. Correction, although small, is achieved through a complex and lengthy intervention, which may include osteotomies of the formed block. The frequency of osteotomies can reach 24 or even 30%. The number of complications after the final fusion is very significant, up to 22–40%, which does not always allow us to call this operation final. In our clinic, in Novosibirski Institution for Traumatology Orthopedics, has been used the Vector till 220.08, and now we have the experience of surgical treatment on 131 patients with early onset scoliosis of various etiologies, of whom 84 have completed a cycle of multi-stage treatment. A total of 48 patients underwent the final fusion stage, 37 boys and 47 girls. The average age of first destruction was 4,5 years. The final fusion was performed at 14 years, and the average period of postoperative follow-up was more than 6 years. According to etiology criteria, the patients were divided as follows: congenital 33, idiopathic 27, syndromic 22, neuromuscular 2. The technique of final intervention in 74 cases consisted in replacing the Vector instrumentation with modern segmental instrumentation in combination with dorsal spinal fusion with local outer bone. The dynamics of the main parameters characterizing the state of the deformed spine is presented in this table. The initial value of the main curve was very severe, 93 degrees, but during the first destruction, it was reduced by more than 35 degrees, which is almost 40% of initial value. Later, at the destruction stage, it was possible to preserve most of the achieved effect. The loss was only 17 degrees. During the final operation, the deformity was reduced by almost 40% and subsequently almost completely preserved. The loss of correction was only 3 degrees. The length of thoracic and lumbar spine increased during treatment and the rate consistent with the normal development of the spinal column. We constantly noted the presence of spontaneous bone block of various localization. Of the fixation point of the destruction rods type 1, upper thoracic rib, lamina of lumbar vertebra, iliac crest, signs of outer fusion were noted in 100% of cases. Blocks of adjacent ribs were often formed in the area of the cranial grip. In the lumbar spine, outer fusions were noted in the area of lamina hook, implantation, and cranially where the destruction rod was tightly attached to the posterior vertebra. As for the type 2 outer fusion, blocks along the lengths of the destruction rod, the picture we identified was completely different. In no case have we encountered blocks of the posterior vertebra throughout the apical and paraapical zones of the curvature. It is precisely this circumstance that we are inclined to explain the significant 29 degrees correction of the main curve during the final fusion. We also did not find spontaneous fusion at the ribs located under the destruction rod. You can see these two clinical cases, one with very good correction and another with big follow-up period and good correction. Type 3 outer fusion of ribs after dissection of congenital blocks was noted in all cases, but these observations are few among our patients. Only 22 complications were identified in 21 patients, requiring repeated intervention after the final fusion. This included 14 implant-related complications, 4 infections, and some others. Discussion. Surgical treatment of early onset scoliosis is perhaps the most difficult problem of spine surgery. Severe progressive spinal deformity radically changes the life of children and his family, requiring long-term multi-stage surgical treatment. Despite considerable collective experience and many publications, the problem is very far from being resolved. One of its important aspects is the development of outer fusion of vertebrae and ribs in the area of implantation of vertebral endocorrectors. The nature of this phenomenon remains unclear, and reliable methods of prevention have not been developed. During stage destructions, their effectiveness progressively decreased, the Sankar rule, and after 5-6 destruction, it drops to almost zero. The achieved correction can only be partially preserved until the age of completion of skeletal formation. Therefore, performing the final fusion, as suggested by the author of the method, seems completely logical and justified. However, practice shows that many surgeons prefer other options to the classic option, such as retaining vertebral destructors without replacing them with segmental instrumentation, or removing them without replacing with other implants. We had never encountered bone outer blocking of the vertebra in the area of main curve, both its apex and paraapical sections. There is only one reason we can explain the discrepancy with the data of other authors. In all cases, we considered it necessary to carefully follow Dr. Campbell's recommendation of the implantation of vertebra. We had never explored the area of main scoliotic curve, even for minimal length. The rod was carried out subcutaneously and fixed to the upper and lower grips, to the ribs cranially, and to lumbar vertebrae, or to the chest caudally. An analysis of the magnitude of spinal deformity, in our opinion, indicate a high mobility of the main curve, during which there are no anterior fusion developed. We believe that these data are evidence that the final stage of surgical treatment of patients with early scoliosis should include removal of the vertebral rods, correction of deformity with segmental instrumentation, and spinal fusion with local outer bone. Conclusion. The reason for the development of spontaneous bone blocks are poorly understood. The problem on spontaneous bone block is closely related to the multi-stage surgical treatment of early scoliosis, the problem within the problem. Methodological correct use of vector reduces the risk of developing spontaneous bone block. In the absence of spontaneous blocks, the development of which is difficult to predict, final fusion is absolute indication, as it provides correction of spine deformity and vertebral balance. Thank you for your attention.